you very much, and thanks for coming to ICIS conference. Like what Dr. Harold said, it's only one football, which is American football. It's very weird in America. There are many weird things. American football, it's called football, though it's not played by foot. It's played by hand. When I first made it to America, there were a lot of things in pronunciation, so I would say aunt for my dad's sister, and they say aunt. So if someone told you, my aunt died yesterday, you tell them, who cares? There are many aunts. There are many of them right there. So oncological liver, not always metastasis. So I would like to thank the organizing committee who chose this title, which challenged me to just think about what can be included in oncological liver, not always metastasis. So I have nothing to disclose, and that's what I'm going to go over. I'm going to go over the pathophysiology of liver metastases, how this pathophysiology would lead to a certain pattern. There are various patterns of metastases. You need to recognize them in order to link them to the primary tumor, okay? If you see certain pattern with some tumor, yes, it can be still metastasis from this tumor, but it could be very unusual that you would think of, you would favor another pathology other than metastatic deposits. Will illustrate various imaging pitfalls and mimics, which can lead to misdiagnosis, and we will provide some clues to the correct diagnosis. Not always metastasis, although metastatic deposits are way more in incidence than the primary liver tumors, and you know, like about 80% are multiple, 20% are solitary. So the incidence of liver metastases, like to the primary neoplasm, are 40 to 1. Okay, there are certain tumors that occur in adults, other tumors that occur in pediatrics. So liver is a fertile solid for metastases. So you see the metastatic deposits second only to regional lymph nodes as a site for metastatic disease. And there are several reasons for liver being a good soil for metastatic deposits. One of them is dual blood supply, in addition to other factors. And as I said, liver metastases generally follow the histotype of the primary tumor. So we're going to go over this and see how the histotype of the primary tumor affect the pattern of metastatic deposits. So there are many patterns, but we choose like some common and uncommon patterns, like diffuse pattern of metastatic deposit, hyper-enhancing pattern, hypo-enhancing pattern, cystic pattern, and then calcified pattern, and fat-containing, which could be microscopic or intravoxel lipid, or macroscopic or bulk fat, you know. So those are alternate terms that are used by experts. And you know, there is a reason why we're you know, seeing a hyper-enhancing MET as hyper-enhancing, and there are some you know, tumors that tend to have this pattern because of you know, things in the pathophysiology, like for example tumors that have vascular endothelial growth factor. Those are tumors that are characterized by angiogenesis, such as renal cell carcinoma, for example, such as neuroendocrine tumor. It leads to hyper-enhancing metastatic deposits, and each of those has a reason for this pattern. Mucinous tumor can be cystic. Mucinous tumor can be also calcified. Fat-containing metastatic deposit can occur rarely due to fat-containing primary tumors. So we need to really have this, because you know, it will make really a big difference in your diagnosis when you prioritize your differential diagnosis based on your thought process, based on pathophysiology of your knowledge of the primary tumor and how it occurs, and you know what the secondary tumor would look like. So this is 49-year-old man with gastric cancer. This was read by a brilliant radiologist in my institution. It was read as diffuse fatty infiltration of the liver. The patient has gastric cancer, right? At this time in CT, it will be difficult really to recognize what's going on. I was the lucky radiologist who is presented by this MRI within a week for this patient. And you can see here what is this going on here. There are diffuse liver metastases peripherally here in the liver, right? So gastric cancer is one of these cancers that that can lead to diffuse pattern of metastatic involvement of the liver. So this is one of the pitfalls that were actually diagnosed as benign fatty infiltration of the liver, while it's actually malignant, it's metastatic deposit with coalescent metastatic disease here peripherally. What is the clues here for the diagnosis? The clues here, if you go back, I have to make this disclaimer that it was actually difficult to make the diagnosis based on this, because it looks like a geographic pattern that you see many times a day in cases of diffuse fatty infiltration. But here, the orientation, the pattern, the distribution of hypo and hyperdensities is different from fatty infiltration. With fatty infiltration of the liver, you expect to see the hyperdensities, which is the fatty sparing more centrally and along the fissures. Here you see the hyperdensities more peripherally and see more of hypodensity centrally here. You go back to the MRI, you see the diffusion, peripherally restricted diffusion. You see also, there was also what added to the complexity of this is that there was fatty infiltration underlying this. So in the background, you see here centrally some drop of signal intensity on out of phase compared to in phase pulse sequence, and this is diffuse metastatic deposit on top of fatty infiltration. So those are diagnostic clues. The other diagnostic clue is you see with fatty infiltration. So you see here abrupt termination of the vessels at the border of tumor. You see some bulge here, which is due to increased cellularity. You don't see that with fatty infiltration. You would see normal vessels traversing through this attenuation difference, and with fatty infiltration of the liver. So those are some key clues, and it's very important, even if you think that there is diffuse fatty infiltration, very important to make this disclaimer in your report. Please note that fatty infiltration of the liver reduces the sensitivity to detect underlying discrete lesions. So it's very important to save yourself by making this disclaimer. So this was diffuse metastases. Second pattern here is hyper-enhancing metastases. With hyper-enhancing metastases, I would expect to see arterial phase hyper-enhancement and washout in the venous and delayed phase like what we see here. And specific tumors like neuroendocrine tumor, renal cell carcinoma, breast subtypes, thyroid, and melanoma, you could actually expect to see this pattern, right? We see, I am presented with this resident. I was staffing a resident, and he told me, I really think of metastatic deposit. The patient has colon cancer. Very unusual pattern for colon cancer to see this intense hyper-enhancement in the arterial phase. It has been reported, but it's rare, so you have to actually, think of an alternate diagnosis, like not being multiple doesn't mean metastatic deposit all the time. And here I was helped also by the hepatobiliary phase, the 20 minutes after injection of Uvest or Primovest, and you see retention of contrast, which is indicative of focal nodular hyperplasia, right? So again, this is an example of that you need to think about what's the primary tumor. Does this link perfectly to the primary tumor, or it's a different type of pathology? And this was focal nodular hyperplasias. And as I said, the resident here was trying to say it's multiple. The patient has primary cancer, so it's metastatic deposits. So you need to think what the primary cancer is and what is the metastatic deposit that could lead to, and what's the pattern, expected pattern. This patient also, has some area of MD Anderson, so patient has primary cancer, and we're presented with this hyper-enhancing region here. It looks like focal, but it's in a specific location, and this was actually misinterpreted again, but it's in a specific location, and you see a vein supplying this. This is actually a normal variant called apparent left gastric venous drainage, okay, and this is what's called the third inflow, because the liver have two inflows, right? The portal vein and the hepatic artery. But if you have another vein independently supplying the liver, you would expect some differential enhancement of this region supplied by this anomalous vein, and this is an apparent left gastric venous drainage. Likewise, you can see what's called apparent right gastric venous drainage again here in this region, and I'll tell you that I see a lot of things that were misinterpreted. A lot of these pseudo lesions, what's called pseudo lesions, misinterpreted for real pathologists. And this apparent right gastric venous drainage when it's actually supplying segment 4. So segment 2 or 3 is apparent left gastric venous drainage. Segment 4 is apparent right gastric venous drainage. And again, you see here the anomalous vein supplying segment 4 of the liver. Those are other locations for pseudo-lesions that could be actually misinterpreted for pathologists, and those are pseudo-lesions secondary to an apparent vasculature. Another thing here, which this is another case, and a patient also with some sort of cancer, and you see multiple hyper-enhancing foci, okay, scattered throughout the liver. You know, in a busy day, you may think that, okay, that are innumerable enhancing lesions, I have to think of metastatic deposits, right? You'll be right in most of the cases, except that in this case, there are some interesting findings. This interesting finding is dilated common hepatic artery, early filling of portal vein, which indicates some sort of arteriovenous communication. This patient has hereditary hemorrhagic telangiectasia or Osler-Weber syndrome that lead to multiple arteriovenous communications that could be misinterpreted for hyper-enhancing masses and could be potentially misinterpreted for hyper-enhancing metastases. Another patient here, we see also innumerable hyper-enhancing lesions scattered throughout the liver. You know, one of the key here that I actually feel more comfortable when I don't see washouts. Okay, this is a rule, but there are some exceptions of the rule, but these are innumerable enhancing lesions. In the delayed phase, you don't see enhancement washout. Some of the lesions are iso and other lesions retain contrast. So this is, you know, some sort of what? This is what's called large regenerative nodules. This is indicated by, it's a vascular disorder, Budd-Chiari, and it's indicated here by a presence of IVC stent within the IVC, okay? Because this was occluded, this segment was occluded, and it was relieved by a stent. And those could be also potentially misinterpreted for, you know, another pathology. But again, large regenerative nodules, I have seen this. It could be multiple or single, but I have seen it a lot to be misinterpreted for another more serious pathology. So those are typically multiple, but Chiari is specific for this entity. You know, if you still read some of the older book, you will see those called nodular regenerative hyperplasia. Pathologically, it's not a correct term anymore. This is a correct term, which is large regenerative nodules, which could be misinterpreted for metastases. Here, there is lack of washout, so typically they don't wash out, and typically they are seen in cases of Budd-Chiari. So don't assume a malignancy just because it was referred to you from another hospital as malignancy. This case was referred to us in MD Anderson as metastatic neuroendocrine tumor. Many of us could say, yes, that's metastatic neuroendocrine tumor. You have enhancing mass, which is hyperintense here in the pancreatic tail, and you have multiple hyperintense, hyperenhancing masses throughout the liver, right? But one of the lessons is you really need to characterize each pathology separately. Okay, this is one of the lessons. Second lesson, don't assume it's malignancy without a pathological proof. And it doesn't mean that your friend, your colleague outside or inside call it metastatic neuroendocrine tumor, you would call it metastatic neuroendocrine tumor, okay? Because I see that also and this is one of the pitfalls that radiologists repeat themselves and repeat the mistakes that were made before them, okay? If you look at the pancreatic mass, it's actually intrapancreatic spleniole, okay? It follows the spleen signal intensity and enhancement. Even this arsinoform heterogeneous pattern of enhancement in spleen, you see it in the pancreatic tail mass. So this is not actually a neuroendocrine tumor. This is intrapancreatic spleniole, which follows the splenic signal intensity and enhancement in all pulse sequences and phases of contrast enhancement. What are those? This woman has history of oral contraceptives, and those were proven to be multiple adenomas associated with intrapancreatic spleniole. You see how miserable the life of this patient would be if we actually were dragged. We actually followed the same diagnosis of metastatic neuroendocrine tumor. Patient after that receiving, of course, not surgical candidate because of the metastases and all of that stuff, and receiving chemotherapy, unnecessary management, and we can just make the life of the patient miserable, while it's just a benign diagnosis here, multiple hepatocellular adenomas together with intrapancreatic accessory spleen. So don't assume it's malignant just because your colleague called it malignant. You need to have a pathological proof here if you're not sure what's going on. Another one that was also referred to M.D. Anderson as enhancing mass assists for vascular encasement. So you already assume it's mass. You already assume it's, and actually it looks ugly. Ugly enhancing, heterogeneously enhancing, irregular mass in the liver, right? I was actually sort of lucky also being referred this case because in the same week we published what's called inflammatory pseudotumor. Inflammatory pseudotumor can look exactly like this, can look ugly, can look hyper-enhancing mass in the liver, okay? The patient, you need to dig in the report here in the clinical history. This patient had removed viral infection, and that is typical clinical history for these patients. And we just talked to the clinician. We ask it to don't be arrogant even for diagnosing a rare malignancy just because you saw it with me now, or we see it somewhere else, or you see it once. This is a rare entity. You need to confirm it by pathology and need to be also conservative when you say it. Could it be? Could it be that entity? And I thought about it because the patient was young, liver is not cirrhotic, tumor markers are not elevated, so, and the patient had removed a viral infection, and this was inflammatory pseudotumor. This has completely resolved after 6 months of high-dose steroids. Similarly here, that was also inflammatory pseudotumor. It looks ugly and looks very hot on PET scan too, right? Patient here has a splenectomy. This splenectomy was because of Epstein-Barr virus. Okay, and the spleen was resected. You have numerous enhancing lesions in the liver, and these were proven to represent also inflammatory pseudotumor, which is myofibroblastic tumor. So when they get the biopsy, you find fibrous tissue, they find inflammatory cells together. This, you can see that in the lung, you can see it in the mesentery, you can see it in the mediastinum, you can see it in the spleen, and in all of these, we said inflammatory pseudotumor. That's an EGR article that we published back there in 2003, I think, and all of these have potential to be misinterpreted. No matter of fact, I think I would say more than 90% of these could be misinterpreted because of their mass-like appearance and enhancement. And we said it's the great mimicker. One other thing it could mimic also hyper-enhancing masses, which is that pathology within segment 4, hyper-enhancing area within dilated collaterals. We all know what is this. This is superior vena cava syndrome that led to these collaterals and hyper-enhancing lesion in segment 4. This is an entity that has been described in the literature, and every time I show it, people can mistake it for hemangioma, just because it fills in the delayed phase, but it fills in and leaves out a hypointense area in the periphery. This is what's called the peripheral washout sign. This is actually very specific for malignancy, particularly metastatic deposits, and in particular colon cancer metastatic deposit. Okay, and also this was actually, it can be potentially misinterpreted for hemangioma just because it fills, but this peripheral hypointense or hypodense rim is a diagnostic for what's called the peripheral washout sign, and this was colon cancer metastatic deposit. Similarly, here you see the same finding, which is peripheral washout sign. This is cholangiocarcinoma. So it could be seen in primary, such as cholangiocarcinoma, or secondary tumor, particularly with colon breast cancer, that these patterns I have seen. And this should not be misinterpreted for hemangioma. This is malignant tumor. In matter of fact, this paper is saying it is diagnostic of malignancy. It's a specific sign for malignancy. Okay, so I have to run with these. So another thing, another pattern here that I want to go over is delayed enhancement pattern. Okay, so this mass, this patient has colon cancer. I'm going to show 2 cases. I'm going to wrap up with this. But this patient has this hypoenhancing lesion in early phase, completely fills in the late phase. It was diagnosed as hemangioma. The patient here has colon cancer. Okay. Second patient here was diagnosed as metastatic deposit. You have continuous rim of enhancement and fills in the delayed phase. Okay. The previous one was actually metastatic deposit. The second one here was sclerosed hemangioma. Okay. I'll tell you what the key difference between this. Hemangioma follows the blood pool. So this metastatic deposit, I would really suspect it as metastatic deposit because it just fills in, but it doesn't follow the blood pool. This one, I would still say that this could be sclerosed hemangioma because it follows the blood pool. Okay. At least in these cases, I would ask for biopsy. I would not be too arrogant and say, I swear this is hemangioma, I swear this is metastatic deposit. At least I would question them because normally and typically people don't question that, and the radiologists here called this hemangioma and later on came back after a few months and was biopsied and was found to be metastatic deposit. Similarly, the radiologist here called this metastatic deposit while it was sclerosed hemangioma. Why it's linear, continuous, rather than nodular discontinuous? Because sclerosed hemangioma can lose this peripheral discontinuous nodular pattern, and they can look exactly like that. So this is a blood pool enhancement. I don't wanna, I have several other cases, but I don't wanna take more time than this. This was misinterpreted. The patient has HIV and they have this lesion here. And if you actually look at it, it's ill-defined, sort of coalescent, and it also follows the blood pool. And when was this biopsied, was found to be something weird, but now I'm familiar with it because I have seen few cases with that. It's pileosis hepatis, and pileosis hepatis is dilated blood sinusoids. And this is again another form of pileosis hepatis, and it's another form of pathology that follows the blood pool. Okay, that's why you see them as coalescent. Sinusoids are very tiny, but when they coalesce together, they can look exactly like what I showed you, and they follow the blood pool. This is the key for the diagnosis. I'm gonna run and just give you the conclusion, give you take-home lessons. There are many cases, others, I can go over them maybe in the drink outside or. So the conclusion here is that you need to look for the pattern of metastatic deposit because it really should follow the histotype and should be affected by the pathophysiology. Diffuse fatty liver limits the evaluation of focal lesions, and coalescent metastases can look like diffuse liver infiltration, and diffuse liver infiltration could also mimic diffuse metastases. Do not manage malignancy, so you don't rush to manage them without pathological proof, and I'm reminding you with the case of splenule and adenomas. Correlation with laboratory and the clinical findings is very important. I was going to show you a case of multiple abscesses with colonic wall thickening that were misinterpreted as colon cancer with metastatic disease while the patient actually was symptomatic. Okay, so we need to actually link your diagnosis with the clinical context and laboratory context, correlation with the clinical history. And I have a case that I didn't show you, I didn't have time to show you. It was like Surgicel, like hemostatic surgical backing that looked like recurrent mass, while, just your knowledge that the surgeon has put something to stop the blood flow, the blood oozing of the blood and the bleeding would actually give you a way for diagnosing this. So I'd like to thank you very much for your listening and enjoy the rest of the conference.